Well, now that we have quorum, I think I will call this meeting to order. And what we have, I think, unanimously decided is the very first trans-provincial Atlantic Canada meeting of seniors using virtual technology. So welcome to our panelists and all of our participants. My name's Anthony Quinn. I am the Chief Community Officer at CARP, working out of my home just outside of Toronto, Ontario. I'm pleased to be the technical director for this meeting this morning. As I look at my screen, I just want to point out who we have on the panel today. I will not provide the full biographies. They will be introduced to you prior to their speech, but I see Alphonse Dion, and he is the president of the New Brunswick Senior Citizens Federation.
Good morning.
Thank you, Alphonse. I see Vicky Bryanton. Vicky is a consultant in PEI and is a consultant to charities and not-for-profits. Sharon Callahan is the next on my screen, and she is the president of the CARP Newfoundland and Labrador chapter. Hello, Sharon.
Good morning.
Next on my screen is Bill Van Gorder. Bill is a member of the board of directors of the CARP Nova Scotia chapter and is a vice chair of the national board of directors of the CARP Association. Good morning, Bill.
Good morning, everyone.
Dr. Suzanne Brake is the advocate for seniors for the province of Newfoundland and Labrador. Good morning, doctor.
Good morning.
Ron Swan is next on my screen, and he is the president of the CARP Nova Scotia chapter. Good morning, Ron.
Good morning, everyone.
And last but not least on my screen is Dr. Shelley McNeil. She is a Nova Scotia physician and a professor of medicine at Dalhousie University. Good morning, doctor.
Morning. Thanks for having me.
Thank you all. I will just once again remind all the participants that are listening into this video conference that you will have the opportunity to ask your questions after the keynote presentations from our panelists. So please hold your questions, or you can enter them into the Q&A or chat functions in the toolbar at the bottom of your screen. And we will invite you to ask those questions a little later on in the program. So without further ado, I wanted to hand off this meeting to Bill Van Gorder, who will introduce CARP and what we're intending to do today. Bill, over to you. Thank you.
Well, thank you very much, Anthony, and welcome to everybody who has joined us today. This is not only the first of Atlantic-wide, all four provinces, opportunities for older adults to get together under the auspices of CARP, but also one of the largest meetings that we've held in some time. And we're also pleased to know, and many people know, that the event is being recorded, so it will be available to those who couldn't make the time this morning to see it at a future date. CARP is a national organization dedicated to advocacy for older adults. And as such, we look at all areas of concern, but especially these days, we're looking at the effects of COVID-19 and the situation that we're in right across Atlantic Canada, and that's what we're going to be dealing with today. If after this session you're interested in learning more about CARP, please don't hesitate to go to our website, very simple, carp.ca, or search us on Facebook. There's a Facebook page for all our individual provinces, as well as a national Facebook page, and we urge you to learn more about CARP. But I'm not going to take any more of our time now because we want to hear from our four panelists, so turn it back over to you, Anthony.
Thank you very much, Bill. The first item on our agenda is to hear from Sharon Callahan. She is the president of the CARP Newfoundland and Labrador chapter. Sharon, thank you very much.
Hey, good morning, everybody, and welcome to this first Atlantic virtual meeting for our CARP chapters. And Newfoundland and Labrador is absolutely delighted to be participating in this venue today. We jumped at the opportunity when the idea first occurred that we might have an Atlantic meeting, and we've been planning this now in a short order, about 2 to 3 weeks, not very long. And we hope that at the end of this presentation, it would have met the expectations that you have for it. We certainly hope that hearing from you and hearing what the learnings have been, what we have heard from the different, from our different communities, will be what drives us into going forward with our actions for the remaining months of this year and on into the future. Certainly here in Newfoundland and Labrador, our learnings have not been different from any learnings that I understand my colleagues in the other 3 provinces have heard, and they're across Canada. If one thing is a certainty, and that has been that a lot of us who have been advocating on behalf of seniors over the past little while have somewhat felt like a little bit of advocating in the wind. This unfortunate time we have found ourselves in has brought credence to a lot of the things that we have been saying. And so our learnings are not unique to Newfoundland and Labrador. They're common across the Atlantic region, and they are common right across the country. As the Prime Minister, when he gets on TV in the daytime, always says, we're in this together, and this is the one time when we need to work together, and I'm pleased that today we're able to do that. So without further taking up too much time, it is my pleasure to introduce to you Dr. Suzanne Brake, the Seniors Advocate for Newfoundland and Labrador. Dr. Brake has a long history of involvement in the area of aging and seniors, which includes clinical, managerial, administrative, teaching, research, and policy experience. I don't think there's much else left to be covered. Following her appointment as the inaugural Seniors Advocate for our province, Dr. Brake spent the first year consulting, collaborating, and collecting information on the systemic issues that were of critical importance for seniors in our province. And her first report was released not quite a year ago, and I was present at that at the release of her report, and it has been a cornerstone of the actions that need to be taken in our province, and I'm sure there are very many commonalities with what the other experts on our panel have heard as well. She's spoken publicly during this pandemic about the issues that have impacted seniors, and she has challenged government leaders and officials to implement the changes in her report and that have been verified by the learnings of these past few months that will better the lives of all seniors. So without further ado, I welcome Dr. Suzanne Brake.
Thank you so much. Thank you, Sharon, and thank you to CARP Atlantic for inviting me to be here today. Anthony has explained that I can put my my slides up, but I have a question for the others. Are the others going to be using slides as well, the other presenters? Yes, in that case, I will do it. If you weren't going to do it, I wouldn't. But I will do that. And just give me a second now, and I'm hoping I'm going to get this right. And
You're good.
1 second now. I can even get this better, I think, from beginning. There we go. Are we good?
Looks
Excellent.
great. Thank you.
Excellent. Excellent. Thank you. So, first of all, Sharon, when you started introducing me, you said I had a long history of working with seniors. And you're right about that. I've been interested and been an advocate for most of my working life, and perhaps even earlier than that, given the fact that I grew up in a family, a large family, and with many many older persons, many grandparents and aunts and uncles, et cetera, who were very much integrated in a part of my life. And I certainly think that when I did my PhD and I looked at the whole reason why do some people, although smaller numbers, want to actually work with the older adults, then when we looked at the outcome of that in terms of valuing aging, then certainly that was an impact. My earlier life experiences as well as later experiences was certainly an impact on that. Sharon knows that I can talk and I can talk and I can talk. So when I get close to my 10 minutes, Sharon, just go like that or something. Just tell me, say, that's it, no more. But so basically, as a seniors advocate, I am a member of an office which reports directly to the House of Assembly. It's an independent office, and its the mandate comes from an act that was proclaimed in July of 2017 and regulations that went with it. And then in November 7th of 2017 was the day that I was actually appointed as the first seniors advocate in Newfoundland and Labrador. I'm not going to go through everything there is about the act and what definitions mean and all of those things. You can go look that up online, but I will tell you that it was clear, and it's actually in the act itself, that I have the authority and the ability to explore and look at systemic issues impacting what we call senior services, which fall within 5 broad categories. And there's no one on this line who would not agree that these are the 5 broad areas which impact us as seniors as we grow older: healthcare, personal care, housing, transportation, and finances. And they're not unique and identifiers in and of themselves, but they are certainly very integrated at times. Sharon explained that I went through a process of consultations and meetings and research and whatever. Well, that's all been part of my life throughout my whole lifespan. I worked 11 years in a long-term care facility. I've taught at the university. I've worked in acute care. I've had lots and lots of community involvement and personal involvement. Recently, I was a carer, as the new language is, which I actually like that language, a carer for my own husband who recently passed away just 6 months ago. He had frontotemporal dementia. So I understand that piece as well, very intimately. I'm going to go to my next screen now, and we're still good. You can still see all this? Okay.
We're good.
Okay, good. So the role of the office and part of my job description is to identify and to review and to analyze systemic issues impacting or related to seniors. And sometimes people call this office with individual issues because they think, well, she's a seniors advocate, then she should be able to help me navigate my way through systems. And, of course, we never turn away any call, but we have other ways and abilities to address individual issues. So we try to focus our energies in this office on what those bigger systemic issues are. We have, organizations such as CARP, or in the Coalition of Seniors Organizations, retiree groups, and we have 50+ clubs in Newfoundland and Labrador. And we have what's called Seniors NL, which looks at information and referral. And we have another legislative office called the Citizens Representative, which can actually advocate and explore what people might believe to be, grievances they might have on an individual level with the system. The second piece of work that we do is we work collaboratively with those seniors organizations and with those service providers and with others to identify and address those systemic issues. And then what we do is we make recommendations to government and government agencies respecting changes to improve seniors services. So what came about in terms of the consultations we've done, and with ongoing work all the time, of course, is that I released a report last fall in September. And at that time, there were 3 major areas we identified. And of course, aging in place was one of those big areas, healthcare. And I was a little surprised, and I shouldn't have been, having been somebody who's worked all my life outside my home and inside my home as well, I might add. but that the labor force participation had emerged as such a big issue amongst seniors in terms of wanting to continue to be engaged and involved. And so those were three big major areas. So within those three major areas, we identified 11 areas of specific concern at this time and 25 potential actions. So and I think Sharon may have circulated our report, which is called Long May Your Big Jib Draw. And I think anybody in Atlantic Canada understands what that means. And I myself, my husband was a sailor. We did a lot of sailing. So yeah, long may we live in life, and you know, and our jibs, which is of course a main sail, or the big sail on the boat, one of the sails on the boat, may that jib be filled with air and propel us forward in life, and we live good, healthy, happy, long lives. And so basically, so what I wanted to get into, because I know 10 minutes goes fast, and as you can tell, I like to talk, is that what came out of that whole consultation process was, number one, the public became aware that there is a seniors advocate, and that advocate has a responsibility to identify on behalf of seniors and older persons in our province, you know, what those major systemic issues are and how we're going to best move forward with them. And what we recognized up front was that there was an overarching issue, and I have believed in this for many, many years, that impacts why we end up having these challenges. And that's the whole issue of ageism, and basically discrimination based on age. So we have identified that in our report in terms of how can we best address that. So pre-COVID, well, for starters, in Newfoundland and Labrador, you got to remember, we had COVID in March, but prior to COVID, we had one of the biggest snowstorms that you could ever have imagined in this province. It actually shut down the east coast of Newfoundland, and for 2 weeks we had a state of emergency. So it's been really interesting, because it's starting then, that's when we started to recognize the challenges that people as they grow older actually have, in terms of how do you actually, you know, shovel the snow? Who's going to shovel the snow? How am I going to get my groceries? And so on and so on. So, you know, so basically pre all that, we already recognized that there were a number of different issues which impacts seniors as they go along. But the two things that my office decided that we were going to look at in depth and make specific recommendations about at that time was the whole issue of homelessness. And I can't speak on behalf of the other Atlantic provinces, but certainly we see homelessness actually in Newfoundland and Labrador amongst older people. And that's a very sad and poor reflection on society and humanity when that is actually happening. So that was one issue we started to work toward. And also the whole issue of access to dental, vision, and hearing. Because in Newfoundland and Labrador, unless you have some kind of a plan, then these things are not usually offered and supported through our provincial system. So those were the two things that we started to work towards. And then all of a sudden, Sharon's given me my cue. You know, then Snowmageddon happened and COVID-19 happened. So what's happened since then is that we have been totally, completely involved with speaking and advocating on behalf of seniors in our province. First of all, regarding dispensing fees, and I know that has impacted people right across this whole country, but it was an extremely stressful time for people because dispensing fees can take up a lot of your income. The second piece, which is the most important thing to me, and that's the whole issue of long-term care. And prior to COVID, we had committed that we wanted to do a review of our long-term care system. And when I say that, I mean long-term care facilities, personal care homes, and our home support program. Because of course they all, and then acute care as well, because they all have to knit together. And because we felt that there were systemic issues that are embedded in having a long-term care system, which is promoting and fixated almost on having large long-term care facilities. And I actually did a call, and a number of times I've asked for why can't we just, basically stop building long-term care facilities? Why can't we be like Denmark in 1988 and just say, this is it, there's a moratorium on building any more of these big buildings? And I think we can, because as people, we're the ones who support this and allow this to happen. So basically, the long-term care has been an issue in terms of staffing, in terms of infrastructure, in terms of many, many different issues. But the thing that has really impacted Newfoundlanders and Labradorians since March in long-term care facilities has been the issue of visitation. So in March, our public health director, God love her, because she's doing a fabulous job, but she had to make a difficult decision of saying no visitation in long-term care facilities. Now, on one hand, we don't have people dying of COVID in our long-term care facilities, fortunately, thank goodness. But on the other hand, we have the impacts of social isolation, and that's been a huge, huge issue. So right now, one person, designated person, is allowed to visit long-term care, but that's becoming a real challenge for both the people who live in the long-term care system, but also the people who need to visit, who want to visit, and who want to support that system. Because of course, the value of the unpaid part of family, is extremely important. So the third piece is about Snowmageddon. So I'm done now, because I've got there's my contact information. But
final point, Suzanne.
So thank you very much. I guess social isolation goes without saying. In terms of throughout the whole system, seniors were worried sick about how we're going to get our groceries, how we're going to get around, how we're going to get to medical appointments, etc. And then, of course, it was even more compounded within our long-term care system. So that's just a snapshot in 10 minutes of what my office is all about and what we're all about.
Thank you very much, Suzanne, and thank you for that snapshot of what are the big issues here for us in Newfoundland and Labrador. So Bill, I'll pass it back to you for the next introduction area.
How do I get out of this?
And I will pass it on to Ron.
Yes, good morning, everyone. I'm president of CARP Nova Scotia, and just listening and looking at, we've got almost 200 participants on this call this morning, and this virtual meeting has really given us all an opportunity to collaborate in Atlantic Canada, like maybe we haven't collaborated before, and we should do more frequently. So really excited by this opportunity. It's been about 14 years ago, I guess, since CARP started in Nova Scotia. It was founded by the gentleman maybe in the middle of your screen, or certainly in the middle of mine, Bill Van Gorder. So I fondly refer to Bill as the father of CARP in this region.
As long as you don't call me the grandfather.
I think there's a lot of grandfathers on the call right now, Bill. So anyway, that being said, our priorities, we've got almost 10,000 members here in Nova Scotia. So CARP's been very successful here. Our priorities are healthcare reform, financial security, seniors housing, aging at home, aging in your community, and the environment. And we've got committees working in those areas to make a difference. At the same time, too, we also participate in what's known as the Seniors Advisory Council, or Group of 9, which is 8 other seniors organizations along with CARP to make up the 9. And collectively, we speak on behalf of over 120,000 older Nova Scotians. So well represented in this province. We meet with the government, Department of Seniors on a monthly basis and champion the causes of older Nova Scotians. That being said, I'd like to introduce Dr. McNeil. Dr. McNeil joined the board, and I'm thinking, Shelley, it's been a year or 2 years ago now, so approximately. Dr. McNeil is She's a professor of medicine and clinical scholar at Dalhousie University. She's the division head and service chief of the Division of Infectious Diseases at the Nova Scotia Health Authority and research director of the Division of Infectious Diseases. Dr. McNeil is an accomplished researcher who completed internal medicine training at Dalhousie, followed by fellowship in infectious diseases at the University of Michigan School of Medicine. Dr. McNeil is also the deputy director of the Canadian Centre for Vaccinology. Her research focuses on immunization policy, evaluation of epidemiology, and boy, I vowel with that one now, of vaccine preventable diseases in adults that focus on older people. Dr. McNeil, thank you so much for being here this morning and speaking to all of us. Maybe I could pass it over to you, please.
Sure. Thanks so much for having me. I apologize I didn't have time to make slides. I eat, sleep, and breathe, well, mostly not sleep, COVID these days. I am, as Ron mentioned, the Chief of Infectious Diseases at the Nova Scotia Health Authority. So my main job over the last several months has been to help with health system planning in the response to COVID, both in the acute care setting and as much as possible providing support to other health sectors such as long-term and continuing care, but also working with public health to think about strategies that we were using at the beginning to sort of shut the place down, and now strategies that will allow us to safely open things back up. So just when we thought that we might get a little bit of a reprieve, of course, the health system and the economy decided they needed to open up quickly, and therefore the activities that we've been doing within NSHA to sort of anticipate and plan for that reopening have made us at least as busy as we were in the early phases. So Bill did give me and Ron some things you were hoping I'd speak about. Perhaps my best my most useful thing here may be to answer your questions. I know people have many questions about what happened so far, what to expect in the future. I mean, we know that Nova Scotia was, we were reasonably successful in controlling COVID. We have a very committed and compliant population, and largely with respect to the public health measures that were put in place very successfully to control spread of coronavirus within Nova Scotia. We did have over 1,000 cases and 63 deaths, however, so we weren't entirely successful, not as successful as some other provinces. Our large case numbers do to some extent reflect the fact that Nova Scotia has been a leader in COVID testing. I don't want to sound like Donald Trump, but you know, we were testing large numbers of people, so we were able to identify not only the sort of leading edge of the very sick and hospitalized, but also the large numbers of people in the community who had less symptomatic or even asymptomatic infection. But that being said, we did have 63 deaths, and the majority of our activity in Nova Scotia really did relate to the long-term care setting, largely relating to a single facility. And I echo Dr. Brake's concerns about long-standing deficiencies in the long-term care sector in Nova Scotia, which I suspect are shared across all of Canada from what we've seen of the epidemiology of COVID in Canada. I think, you know, reflecting back just in terms of the work that I've been involved in, we, pandemic planning in any form largely relates to how do we ensure that the healthcare system, the hospital-based healthcare system, can respond to large numbers of sick people, whether they need hospital beds or they need emergency room visits or they need ICU beds and ventilators and the like. COVID has been an interesting experience because we did what pandemic planning principles would suggest was the right thing to do, in that we very rapidly at the beginning of the pandemic in Canada started to empty hospital beds and started to ensure that we would have capacity if we had a lot of sick people coming into hospital. In doing so, though, the only place to put people was in long-term care facilities, because as you know, in most areas of Canada, a significant number of acute care beds are occupied by people waiting for long-term care placements or potentially care in the community. So we did what we thought was right in largely emptying acute care hospitals into long-term care facilities, which in turn made it very, very difficult for long-term care facilities to respond when they had cases of COVID. So our largest long-term care facility, in which really was suffered most of the cases and deaths related to COVID in Nova Scotia, really had nowhere to go once they had patients. So they had cases early on, they were doing all of the right things, they were doing what we would call cohorting and keeping everyone who was known to be positive in one location. But unfortunately, they had such limited capacity that once they exceeded the beds they had available for COVID, they had COVID all over the facility. So how we're going to learn from that moving into the second wave, and I'll talk a little bit about that since you'll ask me, are we going to have one? How are we going to plan differently moving into the second wave is a very, very, very big challenge, because as is the case, I'm sure, in all of your provinces, we have limited capacity in both settings. So we don't have enough hospital beds at the best of times. We don't have enough long-term care beds at the best of times. So where do we shuffle these beds around to make sure that we have capacity in both places to deal with cases in the fall is the $1 million question. I think we will be, we will have ongoing problems though in the long-term care setting unless we can open up some capacity. And importantly, I think unless the government responds very quickly and aggressively with better staffing in long-term care facilities, because you cannot, in acute care hospitals, we cohort patients, but we also cohort healthcare staff. So if you're taking care of COVID patients, you're not taking care of any other patient, which obviously reduces the chance of passing COVID between patients or residents. When you're in a long-term care facility, you've got staff that are going between multiple floors, multiple patients, some who are known to be COVID positive, some are not. It is inevitable you'll see the results that we've observed in long-term care, and they're nobody's fault. It's simply an issue of inadequate staffing to allow you to properly cohort positive people and their care providers away from negative people and their care providers. So that will be the challenge moving forward. In terms of, what will we, I was asked, I think, in the list of things that you asked me to think about, what will the future look like? So you've seen that we are fairly rapidly, and perhaps more rapidly than public health and infectious disease people would like, reopening the economy. We are seeing lots of businesses opening at largely close to full capacity. The clear expectation, of course, is that all businesses are practicing social distancing or physical distancing. But as you've probably seen out around the community, that's very difficult to do when people are, have been stuck at home by themselves in front of their TV for so long that social distancing is not happening ideally. So we do expect that we will see over the summer smatterings of cases. We, in Nova Scotia, I think, did wait long enough that we're not likely to see a huge amount of community transmission related to cases within the Atlantic provinces or people coming from within the Atlantic provinces. But as the borders begin to open up more and we see more travelers coming in, I expect that that's how we'll start to see clusters happening across the Atlantic provinces. And I think in addition to sort of advocating for resources in long-term care, the other place we should be advocating is for more resources in public health. There really are, literally maybe not quite 2 handfuls of people managing this pandemic. In terms of how we stop things from getting crazy in the fall, we need to be able to do testing. So we need to have lots of testing out there, so we're identifying any cases we're not aware of. We need to be able to find and isolate those cases. track their contacts, test their contacts, isolate them if need be. And that in that way we see little blips, but that are quickly eliminated by proper contact tracing and isolation. That, though, is predicated on having people to actually do that work, and we don't have that in Nova Scotia at this moment. We have a very committed and talented team of public health practitioners, but as I said, they're in very small number and they're all very exhausted from this first wave. So advocating for better public health resources will be critical. The other thing I think we need to advocate for is better support for infection prevention and control, both in the acute and long-term care setting. This is something, as you know, I've been chief of infectious diseases for 5 years. Lynn Johnston before me was chief for many years. We've written about 20 business cases saying why not having sufficient physician support to infection prevention and control will lead ultimately to disaster. This would be that disaster. So we have, 4.5 infectious disease specialists in all of Nova Scotia helping manage this pandemic and being responsible for infection prevention and control. That is not enough to successfully and safely manage this pandemic moving forward. So any kind words you would like to say to government about infection prevention and control would be very helpful for us. In terms of what people expect, there's a couple of different scenarios as to what we may see. We may see just low-level transmission of this novel coronavirus in the population, like the common cold, where we'll see, cases coming in throughout the year without significant blips that lead to hospitalizations and deaths. That's probably the least likely scenario in this season because we have so few people that have been exposed to the virus before. So what's more likely is one of two other scenarios: a big surge in the fall, probably or just before we start to see influenza circulating, and that will be related likely to importation of cases from outside of the province, and then laxity in the public health measures because people are sick of them by then. And we'll start to see transmission, get a big surge in the fall, and then go back to seeing smaller peaks and valleys. And that's the scenario that the Public Health Agency of Canada has asked provinces to plan for. And the third one, which is I think probably our goal right now, is that we keep public health measures strong, we keep people aware and compliant with those measures so that we do see these little blips. We see a cluster of cases in one area, we jump on it quickly, we contact trace, we isolate, and it dies off very quickly without overwhelming the healthcare system. So that's sort of why we need people to recognize, we talk about the paradox of prevention, and that is that when something doesn't happen because you've taken a lot of measures to prevent it, there is a group of people who say, well, there you go, I told you were overreacting, I told you we didn't need to do all this crap, I told you we didn't need to not let me come to the hospital to visit my wife, et cetera, when in fact it is those measures, and we know it's those measures because we've seen what happens in the US when we don't take those measures. It really is those measures that have kept us where we are, and we need people to keep following them. In terms of vaccination, so for older people moving into the fall, we will not have, of course, a coronavirus vaccine yet. We do have at the Canadian Centre for Vaccinology 2 active trials looking at novel vaccines. There are quite a few out there. I've lost track of how many in the world are being tested, but this is not a slam dunk for a vaccine. When we had the H1N1 pandemic, we were dealing with a virus that was certainly genetically different than other flu viruses, but it was a flu virus. We knew how to make flu virus vaccines, and the vaccine was developed relatively quickly. Even then missed the pandemic, as you recall. But this time, this coronavirus is not as easy to develop a vaccine against, so I wouldn't hold your breath for a vaccine. It will be important that older people try to keep themselves out of hospital emergency rooms and hospitals by getting the other vaccines that can help do that. Influenza vaccine will be very important. The healthcare system is likely to be very overwhelmed if we see coronavirus and flu circulating at the same time. So anything we can do to mitigate flu this fall will be critical. There is a high-dose influenza vaccine called Fluzone High Dose that's about 25% more effective than the regular seasonal influenza vaccine. It is going to be used in long-term care facilities across the country, I've heard, even in places that weren't previously using it. The federal government's funding it, but it isn't used in our province or many other provinces for people under the age of 65 or over the age of 65, not in long-term care. So they will have to try to purchase it if possible. Pneumococcal vaccine, or the vaccine against pneumococcal pneumonia, also very important for the same reason. And then, of course, the common sense precautions. I recognize that everyone's socially isolated. I have parents who are in their late 70s, and you know, it's been a strain for them. I think they look and seem more frail perhaps than they were before the pandemic, though I feel like I'm older and more frail than I was before the pandemic, so perhaps that's just everybody. But you know, it has been tough, but I think people have to take responsibility for themselves. Be aware of the risk around you, be aware of the risk in your community, watch the news and the epidemiology, avoid high risk situations. So, you know, the bigger the crowd, the closer the contact, the higher the risk. So if you can manage to get a social circle, sorry, just one sec. If you can manage to get a social circle, sorry, my computer died there. You know, if you can manage to find a group of people that are largely keeping to themselves, you know, we're getting away from the bubble term, except for the Atlantic province bubbles, but, you know, if you can find a group of people that you're comfortable with, that are largely staying away from other people, that you can get together with and socialize, you know, that's the best way to protect yourself and stay away from big crowds and close contact. Lots of talk about masks. Right now we're encouraging but not requiring people to wear masks. I wouldn't be surprised if masks become mandated if we begin to see significant transmission in the community. I think it would be, personally, I think it would be crazy to mandate them at this point, but I do think it may come to that. I think that's all I have to say for now, but I'm happy to take your questions after the panel.
Thank you, Dr. McNeil.
You're welcome.
Thank you. I would like to, we will have questions, of course, at the end, but I would like to now introduce Vicki Bryanton from Prince Edward Island. We don't currently have a chapter active on Prince Edward Island. We had one until about 2 years ago when illness of the leadership unfortunately took the leadership away and a number of people. So if after today's event, there are people who want to join us in our advocacy and our work with the other provinces across the country with CARP from Prince Edward Island, please get in touch with me or with Anthony, and we'll be glad to give you the support that we need. I'm planning to visit Prince Edward Island this summer, and if you're interested, I'll come and visit you too after I've been to see Vicki. Now I want to introduce Vicki Bryanton. Vicki Bryanton is the former CEO of the Lung Association of Prince Edward Island, where I first got to know her. And she has over 30 years experience working primarily with not-for-profit organizations, especially in the areas of disability support, chronic disease management, and frailty connections. Vicki has a special interest in public policy, practical supports for health management, the needs of people in rural areas, and the impacts of social change on the lives of older adults. So from that, you can see why Vicki was a very appropriate person for us to invite today, and we're honored to have Vicki Bryanton with us from Prince Edward Island. Welcome, Vicki.
Thank you very much, Bill, and thank you for this opportunity to bring a PEI perspective. Certainly the needs of older adults in the province has been on my mind a lot during the COVID episode, through personal experience and also through what I'm seeing in my community. And just to bring everybody sort of around to where PEI is, I do have slides up, but for those of you on the phone, PEI's population at the moment is just over 156,000, a little closer to 157,000. We have about almost 20% of our PEI population is 65 years of age or older, and most seniors live independently in their homes in their communities. And we have a fairly substantial home care system, but it doesn't meet quite all the needs that exist in helping to keep people in their homes. But we have over 4,000 public clients receiving home care in the province to help them stay in their homes if they need it. When it comes to our COVID numbers and PEI, we have been very fortunate in that our Dr. Heather Morrison, our Chief Health Officer, and our Premier Dennis King have managed to combine efforts and work collaboratively with their teams to ensure that we've been able to keep our total case numbers down to 27. We have the gender split has been a little more towards men than women, but with those low numbers, it's kind of hard to say if that would be a trend for us. And we've been very fortunate in saying that about a third of them have fallen within the older adult age range. Where testing is still underway. We are up to date with most of our testing. According to yesterday's numbers, we only have 20 results pending. We'd certainly like to see more testing done in PEI, but the reality is we're stretched pretty thin in terms of what our system can manage over on this side of the water. And of course, with the upcoming changes the end of the week, where we will no longer cut off the mainland, you'll be allowed to come to PEI again. Concerns are starting to certainly percolate in the province. I do want to say my perspective starts primarily from the fact that I come from a long line of older women and older women who are difficult, who live long in the community. On the slide that you see presented are three women who are very important to me. The woman in the light blue shirt is my grandmother, who is 95 and turned 95 last September. And next to her is my great aunt, who is also 95, who turned 95 last September. And then my mother, Olive Bryanton, who is 82 years old. They are all community dwellers. They all live independently. Two do live with daughters, at least for a portion of the year. And one lives completely independent in the community. My aunt, my great aunt who lives in the community, lives independently. And a couple of them have some pets for socializing as well. All of these women were very socially active before COVID happened. And all of them had substantial impacts in terms of the fact that they didn't leave home for over 2 months during the COVID outbreak here in PEI. And their contact, the two who were living with daughters had the physical contact of having the daughters in their home, but one actually had no other humans living in the house with her, and so was missing that physical contact. So other than that, they were getting these brief visits, the drop-off visits, where groceries and so on were being dropped off at their door. Two of them, I'm very happy to say, two of these people are also very connected to the internet and use the tools that they have available to them. So my 95-year-old great aunt is very active on Facebook. My mother has more technology than I do and is very connected that way. But my grandmother, most of her socializing during COVID happened over the telephone. And I can tell you that all three women talk about the loneliness, the distortion or the disorientation they felt during COVID, not being able to socialize and to get out the way they needed to. And even as activities are started to return to normal, there was very much a feeling of disorientation in getting out into the real world again. And I can tell you that these three women are no slouches. They're not going to be told what to do. They're not going to be bossed around in most cases, but they were tending to experience more, I guess I would call it ageism. So more attitude about, well, because at your age, you need to be more careful kind of comments than might be experienced by others in the community during COVID. So we have in PEI, one of the responses around this social isolation, Islanders are good visitors, and it was very difficult for Islanders not to go visit their friends and family in the community. But there were a couple of services that were set up during COVID that seemed to help with some of that, but it had very limited uptake as I understand it. So Hospice PEI in our province joined forces with United Way. Hospice usually have volunteers who work in palliative care and who work at home bedside in supporting people through death, dying, and bereavement. And but their volunteers were all pulled back in because they weren't allowed to be going into community at that point in time. So there was some redirection of those hospice volunteers and bereavement volunteers in supporting a telephone line to access seniors in their homes. It was a free service to people. They could make contact with people and recontact them as often as they wanted. So that emerged during the lockdown, and that particular program has now ended. The Red Cross has a friendly calls program. They have trained volunteers and staff who can work on a number of psychological first aid aspects. And that recently was announced that for Atlantic provinces, this would be available again as a telephone support service for up to a year, thanks to some funding from Bell Alliant. So these two programs were meant to do outreach for people who were considered to be at risk or who were suffering because of the isolation that was happening in the province. When it comes to our care facilities, again, less than 4% of PEI seniors end up in long-term care facilities, but we have 9 public facilities that can house up to 595 residents. We have 10 private facilities that can take on an additional 652. Most of those, about 80% of those, would be older adult seniors. And we also have community care facilities that are privately run in our communities. And again, I mentioned before, home care does provide services to the clients, for public clients. I don't have the figures for the private home care though. What we were seeing in terms of long-term care, and again, this is a perspective, a community perspective. This is from what I've been hearing. This is not me delving into what was made public or what was made available through our public health system. But in the picture that people can see on the screen, this is the Candyman behind the window. And the Candyman is the father of a friend of mine. And this picture was taken at Easter time when she was visiting him in a long-term care facility. He is a very social man and has been very involved in his communities. He currently has dementia. He couldn't understand what was happening a lot of the time with the COVID restrictions, the lockdowns, though when it was explained to him, he was very accepting. But this is one of the people who tended to suffer a lot during the lockdown related to COVID. So he has a tender, loving heart. He couldn't understand why he couldn't hug his family and friends who came to visit. He couldn't understand why I couldn't give him candy. That was a big deal for him. He had that need to share and be connected to people. For his family, at this point in time around Easter, there was still only the visitations through the windows that were happening. Today, we know that the restrictions have been eased up enough that we have outdoor visits in designated areas only. That has to be scheduled. There's a maximum of 60 minutes allowed for one visit per week. The visitors there has to be 2 designated visitors at a maximum, and you're not allowed to change out those designated visitors. Of course, the screening, physical distancing, hand hygiene, the mask shield piece, all has to be worn by all parties involved. And there's no sharing of contact or even food or gifts in that situation. Physically, the residents were restricted in, they were being physically distanced within the care homes that they were in. And not only were they being locked down in their rooms, but for many of them, they weren't even allowed to sit in the doorways and see the activity that was happening around them. What families were able to observe through the windows was the impact on 2 sides. The impact on the care workers in the facilities. They had to do a lot of extra work for cleansing, to achieve the cleansing and distancing rules that were required. The residents' social events were eliminated very quickly. There was limited time being spent within the rooms, where normally they would be more social and spend time in the rooms with residents. They weren't permitted. They couldn't accept outside gifts and treats to bring into the residence. And although they did try to accommodate the loved ones as much as they could, there was a limit to their ability and the time that they had for every resident. So some were, in some residences, we did have tablets donated, so electronic tablets donated, cell phones donated, but they often took time from the staff as well in order to help people, residents within the facilities, use those tablets to connect with family and friends or use the cell phones that were provided. And in addition, what families were experiencing was that the care workers were really trying hard to help the families and friends on the outside, but there was a struggle in order to meet the increased communications needs. For the people who are residents, that isolation in the rooms, even away from doorways, they were missing their visitors. They were missing their regular routines. They were missing time outdoors. They were missing time out of the facility, going for drives with friends and family, going visiting. The loneliness was very profound for some people. Visits became harder for families as there was a lot of tears and sadness when people had to leave. What they were experiencing more recently was seeing the deconditioning that was happening. So people who were physically mobile were becoming less and less mobile because of the restricted space they were working in. There were declines in mental capacity, and family even said, I don't know if that's related to their current conditions or if it's something, a progression of a chronic disease they may have. Certainly was a loss of motivation for people within the homes. They were becoming depressed as well. So these kind of profound impacts are starting to take a toll on family members, even as some of the restrictions were easing. So as of last Friday in PEI, we have the visitors, the designated visitors has been increased from 2 to 6. So the original 2 are actually now allowed to have visits indoors, not just outdoors under tents or under screened areas. So there's an additional 4 who've been added to the allotment, but they all have to share the 1-hour time slot. So it's still going to be difficult even with extra visitors. The time for visits, the once a week for 60 minutes seems to be the only thing that facilities can manage. There has been an addition that clergy now has access within the care homes, and they are in addition to the other designated visitors. Some locations are now receiving dropped off clothing or gifts. They're kind of put into quarantine for a few days before they're handed on. Sharing of food is still up in the air. There's still, in most cases, and it's PEI, folks. We're just finishing up our spring lobster season. How hard is it for so many of these people within facilities to not be able to get their lobster the way they usually do? And resident mobility has improved a bit in that there's the residents are going to be able to go out and on the grounds again and use the outdoor designated areas when they're free. But with the deconditioning and the lack of staffing and staff being overstretched with other COVID issues, it's going to be difficult for people to be supported in actually experiencing the outdoors in these long-term care facilities. So the other aspect of this that is impacting everybody I know is the impact of dying and death and the grief procedures that we are so used to, our grief traditions that we are so used to. Loved ones are not able to be there by the sides of their family and friends in terms of when they are dying. Hospice PEI bedside care stopped as well, but they were trying to do some support by bedside for telephone and electronic means. In care facilities, the bedside visits in residents' rooms were allowed. There was a maximum of 6 designated visitors just in recent times, but only 2 could visit at a time, 1 time per day. And then clergy was allowed to visit in addition to that. So that we were faced with a lot of new issues around grief and bereavement, as well as the death and dying. So with the travel restrictions, the gathering restrictions, people could not come together. They couldn't go to different provinces to be with family. Their traditions were hugely disrupted in terms of how you cope and deal with things. And although there were new options that popped up, and I'm one of the people who participated in a Facebook Live funeral, and had followed it up with a Zoom meeting wake of sorts for siblings, it was lacking the physical contact. It was lacking the opportunity to have more people come into the room and to share in the grief. So that was distinctive, I think, for so many people, not just older adults, but it certainly seems to impact older adults in a different way. For PEI, as we're preparing for round 2, I have more questions than answers because I'm in the community, so I don't have the answers. I don't have the inside knowledge of what we're prepared for yet. But for me, it's come up a number of times that I'm concerned about is there a line between protection of older adults and abuse? Where is that line, and have we in fact crossed it right now with our response to COVID-19? And do we need to have that conversation before we go into a second wave? Did we go too far with targeting older adults? Is that an ageist approach? Is ageism restriction going to still be a restriction during reopening? Because I'm seeing that, I'm hearing that from some people where they're being told by their family members, we don't want you going out because you're at higher risk. And it's becoming a concern that this restriction is overly emphasized on older adults in our community. Another question I have is how can we combat the negative impacts on residents of care facilities? We've gone through our first round. What can we do better in the coming rounds? But also I think we need to have a close look at what's the impact on staff and how can we be supported there. So staff within care facilities, staff within public health services, they have done a stellar job in PEI. We can't fault them on the work and effort that they put into this, and what they've rolled out in PEI, we see our success here. But there's going to be burnout. That was a very intense few months. We're still facing some intense months in the future, and we need to be able to support the system as well as support our community members. So those are the questions and the thoughts and perspectives I bring from PEI.
Thank you very much, Vicki. Very much appreciate that thoughtful presentation. And certainly you raised some questions that we all have to follow through in our provinces as we go along. Your comments about ageism and the impact that COVID has on that has been noted by CARP in many places around the country, and certainly one that we're concerned about and want to flag as an issue that could be ongoing. The improvements that we've seen in combating ageism over the last few years seem to have taken some steps backward in the current situation. So thank you, and thank you to all your friends on PEI who have been watching, and I'm pleased to say that we've had some offers already of people willing to help us get the message out directly in PEI from people in PEI, and we'll be in touch with all of you to work on that. So thank you, Vicki Bryanton. I now want to introduce Alphonse Dion, our final speaker, and last only because I guess we put ladies first, Alphonse. I think you understand. We have been working at CARP with the New Brunswick Senior Citizens Federation. CARP, once again, doesn't have an active chapter or chapters in New Brunswick at the moment, and like PEI, we want to revive that again. Unfortunate thing, we had very active people in both Moncton and Fredericton for many years, and then sickness took them away from us. So once again, for those of you watching from New Brunswick, if you're interested, and do know that one of the things that we have been doing is working closely with the New Brunswick Senior Citizens Federation, of which Alphonse is the president. We've had some good successes recently in terms of some of the advocacy we've done together, and we hope to continue to do that. Alphonse, as president of the Federation, before he tried to retire, and I certainly don't think he's certainly not a retiring person now, but he had a career in nonprofit housing, which brought him very close to many of the needs of seniors. He's served on the board of directors of Rooftops International, which is a sponsor and developer of housing and communities in developing countries. So Alphonse certainly has a knowledge of the social issues both in our own country and around the world. He's been very active in the Maple Leaf zone of the NBSCF, the Federation, and now as president is giving excellent leadership, and I'm very pleased that he was able to join us today and talk to us about the situation today in New Brunswick. Alphonse Dion.
Thank you very much, and thank you for the invitation, and good morning everyone that I can see on the screen and the ones listening. As Bill mentioned, I have been president of the Seniors Federation a little over a year now, and I have another year to go. I do have a few people that are interested, by the way, in the CARP for New Brunswick. So, and I'm one of those. So maybe after I finish my mandate with the Federation, I can get involved. The Federation has been advocating for seniors for over 50 years. So I didn't do it for the 50 years, that's for sure. But we are, and I don't have slides, by the way. But we have worked on many issues. For example, rebate on property taxes for low-income senior citizens, guaranteed income supplement. We worked with other groups regarding the passport. We can get a passport now for 10 years. We were part of that fight. The extramural program in New Brunswick, we were part of that as well as part of the development. The assets grabbing when people go into nursing homes, we've been fighting that for many years, fighting against that, taking all assets when someone goes into a nursing home. We're also very involved in some of the issues that were mentioned here already. One of them is the over-prescribing. A few of us from the Federation took part in the conference that was held here in Moncton last fall. And we were about to have someone from that group do a presentation to our board of directors until COVID got involved. So we will be following up on that and getting, because it is an issue that's dear to a lot of seniors, and some of them don't realize it, but some are taking too many prescriptions. Over-prescribing. They're taking prescriptions that they used to take for something that doesn't exist anymore, but they still take it, that type of thing. So we're also very involved in the shingles vaccine. That's one that we've been advocating for the last 3 or 4 years. Ontario, as far as we know, is the only province that gives this shingles vaccine to people over 65. So I don't think I have to tell you, I think most of the people that are listening here have some experience with shingles with the family members and that type of thing. So the people that are under 40 are somewhat immune to it because they get the vaccination, but most of us, I know I didn't. So, but that's very costly. My wife and I both had to get it, and it was quite expensive. So, but we were lucky we were able to get it. The high dose flu shot was mentioned a couple of times here too. We did work with Bill and CARP Nova Scotia and try to coordinate the approach to our governments regarding that. And with COVID coming on, we felt that it was even more critical because we all know the people are saying that COVID we're gonna have a second. I think we're still in the first one. We're going to get a second wave, and it could coincide with the flu season. So we felt very strongly, and we did send a letter to the New Brunswick government, but we haven't heard back. It would be too late now to order it anyways if they wanted to order. But the high dose flu shot is very, very much recommended by a lot of groups, including the United States. They give it to seniors because we all know, Medicare pays for medical care in the U.S. For people over 65. So they get the high dose flu shot to protect them. Another issue that we fought for and we're still fighting is the eye exam. The eye exam for seniors over 65, low-income seniors, because we feel again that like in New Brunswick here, I know it's not the same in every province, but in New Brunswick, eye exams are not paid for, but if you have complications, it's part of the system, it's paid for. So we feel that the system would actually, in the end, save money because it would avoid some complications, which requires a specialist. So that's another one. The home care, this is a more recent one that we, because of COVID again, and as we all heard, and Nova Scotia had most of their deaths, for example, from COVID in nursing home. We just made an approach with the government that to increase the, for example, if a family member wants to take time off and take care of a parent or a grandparent, that they would be compensated somewhat. And again, we feel that the research has to be done, but we feel that that could actually save money in the long run. So, and avoid the need for more nursing homes that was mentioned earlier. I'm trying to, I have a lot of notes here, but I'm trying to touch on most of it, most of the ones that I had prepared, but prescription fees, that was also mentioned earlier. We had many seniors calling our office complaining about the 1 month restriction, and people had to pay the dispensing fee every time. We heard, and what we understood the reasoning behind it. What we didn't agree with was the difference. Everybody was being treated differently. Some people have dispensing fee of $15 every time. Some it's 11, some it's less than that. They're all different, and we felt that everybody should be treated the same. Either they pay their dispensing fee once for the 3 months, or something else to help them. In conclusion, the New Brunswickers care about the aging population and value the contribution that seniors have provided to build the province we live in. Seniors have given so much, they now deserve better. The interest of the elderly should be paramount to the government and citizens of New Brunswick. We are 15,000 members across the province, and we have a very active board of directors, and who are willing and able to sit with government agencies to discuss these issues. We're not just asking for things, we're prepared to be part of the solution. And again, thank you for the invitation, and I'll look forward to questions.
Thank you very much, Alphonse. And I would like to point out, we just heard, you may not have heard yet, but because of federal government funding, a high-dose flu vaccine will be available in New Brunswick in all long-term care homes this year. And I don't think your government has announced that yet, but it's public knowledge. And that's, I know, due in great part to the advocacy that you and your group, and CARP worked a little bit with you on that, did in New Brunswick. So it does show very definitely that organizations like yours can have a positive effect on the seniors' lives.
That's good news. Thank you. Yep.
Yes. So thank you again for taking the time to do this. And I caught your words in your opening statement, and I'll certainly continue to be in touch with you as we share our concerns about the older adults in New Brunswick. And now I'm going to turn it over back to Anthony to lead the discussion.
Thank you very much, Bill, and thank you very much to the panelists for your presentation. We have some questions forming virtually, but I wanted to give the panelists representing our chapters a few moments to ask questions that may have come up specific to the presentations of the doctors and Alphonse and Vicky. So between Bill, Sharon, and Ron, I wanted to open the floor to you first to ask any relevant questions that came up from their presentations.
Okay, well, I'll jump in if that's okay.
Thank you.
I guess, and this refers to things that all panelists said, was the fact of the social isolation, the impact that it had on the overall older population, and now the reticent to return back into normal living as we know normal to be today. So I think I would ask Dr. Brake and Vicky if you have any additional observations you might like to offer there, because clearly that's things that I'm hearing. Folks are afraid, folks are not sure what they should be doing, and not taking some responsibility for themselves to be a little bit more assertive in getting more socially connected. So Suzanne, do you want to go first and then Vicky?
Certainly. I think that there's no question that there was a tremendous amount of anxiety and even fear that came about as a result of the constant messaging that came out, which was focused on seniors themselves. And that message kept saying, well, if you're a senior, then you're at risk. If you're a senior, you're at risk, and we've got to take care of you. It was a paternalistic, maternalistic kind of message. But I understand that we, as a society, that was important for us to remind ourselves that if somebody who is maybe older, who has chronic conditions and diseases, they may fare worse. But I think the message became so ingrained that now it's even hard for people to start to readjust. And I'm talking about people who are generally in the community. I think Vicki just talked about the small percentage of people over 65 who actually live in long-term care facilities. The rest of the people live in the community. So, I think that we've got to do a better job of encouraging people to be reintegrated, but at the same time, just watch out for yourself. I mean, there are many people whose grandchildren were not allowed to visit them during this period of time. And although I can understand and appreciate the fear of them getting the disease from them, I'm not quite sure what's worse, getting the disease or being the impact of social isolation. Vicki?
Anything further to add?
Well, certainly in PEI, I do a lot of work with not-for-profit organizations, and a lot of my recent work is around pivoting what you do in order to be able to function during COVID-19. And for organizations that have a community basis, I am actually redirecting some of their thoughts around older adults and the needs that they might have going into this next round of COVID. The physical activity for people is an important piece. So with so many people living in the community, but feeling that they had to stay inside their physical home and not get out and walk around their property or take a little stroll somewhere, I think has created some more issues for people who were living at home during that time. And certainly the ageist approach of saying, well, just because you're old, you're more likely to run into trouble, or you won't understand what's happening out here. They won't know how to. You won't know how to navigate the supermarkets now because of the arrows and the signage that's there. That kind of attitude is certainly grating on my nerves quite a bit, and I'm talking about it as much as I can to bring it to the front of people's minds. We certainly wouldn't want that kind of attitude turned on us as individuals, and we need to reflect that back to the people we speak to.
Thank you both. Ron, over to you.
Yeah, for Dr. McNeil, I've heard you speak a number of times on the high-dose flu vaccine, and of course it became available in long-term care in Nova Scotia last year, and as we just heard a short time ago, about to become available in long-term care in New Brunswick, which is great news. Do you see is there any prospect at all that it might be available should a second wave come along in Nova Scotia this year?
Well, I think as someone alluded to, the way in which vaccines are purchased makes that unlikely because they placed their orders back in February for the coming season. So it will be difficult, though I suspect not impossible, for provinces to purchase some high-dose vaccine if they chose to. How much, I don't know, because the federal funding, as I understand it, does allow for all provinces to provide a high-dose vaccine for all long-term care residents. So that may create a supply issue for the company that they didn't anticipate. And so between the timing and that more broad use in long-term care, it may be a challenge. It is unfortunate because, we will not be able to, aside from all of the strategies we've been talking about, we won't be able to mitigate the number of hospitalizations due to COVID. But we certainly could improve our chances of having adequate hospital capacity if we could reduce the number of hospital admissions with influenza, which I think we could have done with the high-dose vaccine. So not for lack of advocacy by CARP, for sure, because I know many of you have been advocating for high-dose vaccine for even longer than me, but it didn't get much traction because it is an expensive vaccine, and sometimes budget impact as opposed to cost effectiveness drives decisions.
Thank you.
Ron, I might jump in, sorry, Bill, I might jump in here with a question from our audience, and it could perhaps go to any of the panelists. The question is from Alex Handyside. I believe he's in Nova Scotia. And he asks, what besides the obvious is preventing Canada from nationalizing all or most of Canada's senior care and nursing homes? So the obvious being the money. And as he understands it, Tommy Douglas and the government specifically excluded senior care from public health. Is it time to revisit that decision? So to all the panelists, what is preventing Canada from nationalizing seniors care? Dr. Brake, I might point to you with that one.
I don't mind. Well, I think that we have a real combination of types of long-term care facilities throughout our country. So there is the whole issue of the private sector, the public sector, the not-for-profit sector. There is the power and control over how do we use those dollars provincially, because of course they're health dollars. Therefore, provinces and territories have an ability to decide how exactly they're going to spend that money. I think there's some other issues that go with whether it's under the Canada Health Act or some other type of piece of legislation and regulations nationally. But there's also, you know, all the issues around infrastructure and around staffing, what staffing needs to look like and not. But the bigger issue for me is, you know, we've been talking about here today about the whole issue of, you know, 20% of our population is over the age of 65. Well, how about if I said 80% of our population is under the age of 65? That looks a lot different, doesn't it? And how we look at it and how we interpret it. So, I mean, in terms of integrating or looking at a national program, I do think we do. I've been saying this for many, many years, that we really do need, and we as a society need to start demanding it. And the last piece of that is about inspections. I think that you know, national legislation can really enforce the whole inspection process in the long-term care system.
Thank you very much. Dr. Bill, did you have a question to ask while I pull up the next one?
Yes, one question I think directed at Vicky and Alphonse primarily, and that is we know that there are special problems with our rural older adult population across the country. What specific issues are you seeing that we should be focusing on from CARP with regard to rural older adults? Vicky, do you want to start with you?
Sure. I think one of the things we're seeing is making an impact for people people feeling isolated in rural areas of PEI is the fact that our internet system is expanding, and we've seen sort of a one-stage development where good internet access became more available in the province, and we have a commitment now to increase the level of internet coverage that we have in the province and the speeds of that internet coverage. That not only allows us to have more interaction with people through electronic means, but certain forms of healthcare and support can be delivered in a more efficient way that way as well, or stick more closely to people. We have some of that happening in the province, and I think we need to be able to support more of that. So that connectedness piece, I think, is a critical factor in rural areas. For us in PEI as well, outside of our major center, we don't have transportation. So transportation for people becomes an issue. Normally in rural PEI too, we have people neighbors help each other. But with COVID, it created the unique circumstance and that people became fearful. And that aiding their neighbors meant that they would drop in and leave bags on the doorstep. But the idea of taking you to an appointment or taking you to see family and friends or taking you to some events, that dropped off immediately. So lack of other transportation options becomes a real issue.
Good. Thank you, Vicki. Sorry I interrupted. You faded out for a moment and I thought you were finished, so sorry. But Alphonse, you have anything to add about rural New Brunswickers?
Well, I think I would add, Vicki mentioned transportation, also prescription delivery, for example. I live outside the city of Moncton, and during the high time of COVID, we were successful in getting our prescriptions delivered. And I was wondering if they were, but that's really an issue in the rural areas where, and especially with the 1 month thing was even, compounded that. So that's one of the issues.
Good, thank you. Anthony, back to you.
Yeah, thank you to the panelists. There's a question from Joan McFarland, and she asks, in related to Alex's question, is CARP working on the topic of privatization of long-term care in the Atlantic provinces and in relation to the affordability of long-term care? So perhaps, Bill, you could start us on that topic.
Yes, certainly CARP is concerned about the affordability of long-term care right across Atlantic Canada. One of the issues in dealing with long-term care in terms of that kind of specific is that the provinces differ in the way they fund, the way they handle, and the way they regulate long-term care. So to have one blanket advocacy position for all right across Canada is not practical. And so what we're looking at is, and what we're doing is advocating for appropriate care, affordable care, well-regulated care, well-supervised care in all provinces, no matter what the sector, whether it's for-profit, non-profit, municipal. There are many different levels. So I think the thing that we've begun to understand is that it's not just a difference between profit and non-profit. It's a difference in the way regulations apply to those long-term care facilities in the different provinces. So the issue we're very concerned about, but not specifically looking at one solution will fit all, because it won't.
Anyone else have anything to add on that? If not, maybe a related question as to resources in the Atlantic provinces. A great deal of surgical procedures have been put off related to COVID-19, and there were already wait lists prior to that. The questioner, Jim, asks, he says, I believe we can't forget that prior to COVID-19, we're in great need of doctors in Nova Scotia. What is CARP's position on this point? Ron, do you have any insight into waiting lists for medical procedures and shortage of doctors in the Atlantic provinces?
Certainly, it's been an area of concern for ourselves for some time, and we have been advocating for that. We do understand that some elective surgeries are opening up a little bit more with the reduced restrictions of COVID. Maybe Dr. McNeil could also comment on that as well.
Yeah, so that's been a big part of our activities lately, trying to get things back on track, but balancing the need to have beds available should we see further cases that need hospital beds, while at the same time getting as many people back into surgery as we possibly can safely do. So it's a balancing act between safety and getting services delivered, but we're trying hard. And I guess the other thing I didn't say that I should say, and that's important for all of you, is we have this problem. We've observed that people are not coming to hospital when they should, when they're experiencing complications of medical problems and the like. So we really need to make sure people understand that hospitals are safe places. You're way more likely to come in contact with COVID in the grocery store than you are in our hospitals. We have very good infection control practices, and people should come to the hospital when they feel they need to come to the hospital and not be scared of COVID now or in the future. So please don't stay home when anything's going on that would otherwise have brought you to the emergency room.
Thank you. And another question that was directed to Dr. McNeil was on the efficacy of apps to trace contact for COVID. What do we think about the accessibility of apps, particularly for seniors?
So I must say I'm not an expert on that, and I haven't seen the apps that the Prime Minister Trudeau's been talking about. As I understand it, given privacy related concerns, the apps currently being proposed in Canada essentially just serve as a tool for you to recall exactly where you've been, when you were there, who you were with. They aren't transmitting that information to anybody, so it would still require, if I know there was an exposure at restaurant X, public health could contact you, and then you could go to your app and say, oh yeah, I was there on such and such a date, I was with these people, etc. There are fancier apps that actually let them track exactly where you are all the time, but it's not my understanding that that is the plan in the near future for Canada. And of course, I don't know, but I suspect many seniors would be able to make themselves avail themselves of an app should it become readily available, since many do have access to mobile technologies of some sort. So, but I think time will tell about the apps and whether they make things easier for public health or more complicated.
Thank you. Another question from Linda W, and I suppose it's pertinent in that not all provinces are blessed with a seniors advocate, Dr. Brake. Do we have one in the other Atlantic provinces, and what is the status across the country for provincial residents having access to an advocate in their own communities?
I think that there are many advocates in different kinds of ways, but in terms of a seniors advocate, in BC, Isabel Campbell was the first seniors advocate appointed through legislation, and the second one was in Alberta, and she, unfortunately, they have now removed that position and they've merged it with other advocates like the child and youth advocate or mental health advocate or whatever. So it's no longer a specific position which is designated towards it, and both were very much geared at systemic issues, but in Alberta was individual issues as well. And New Brunswick also has a seniors advocate, but his position was a child and youth advocate, and the seniors advocate was added onto it. That's it in Canada so far. I mean, I think in Newfoundland and Labrador, there was a tremendous amount of advocacy from organizations such as your own, and it became a political commitment, and they followed through on it, and hence is how the actual position became. So through the advocacy, through clear messaging, and then legislation, which we actually have the strongest piece of legislation in terms of creating, because we report directly, in Newfoundland and Labrador, we report directly to the House of Assembly.
As Ron mentioned in his introduction, Nova Scotia has a Department of Seniors, a Minister and Deputy Minister of Seniors, and the group of 9 Seniors Advisory Council. So that is that's the advocate position for seniors in Nova Scotia.
Thank you. This is a question from Alex and Elaine, and it may go to Vicky, perhaps. Are there any initiatives to make sure that seniors in care homes are not neglected or taken advantage of because loved ones cannot check in on them during the shutdown or social isolation? This has been an ongoing issue.
I'm not aware of a program that covers that, but I don't have access to all information on that. One of the advantages perhaps in PEI when visiting was allowed within centers is that many islanders have no fear of speaking up on behalf of somebody else if they see something that's amiss. But there's certainly the risk is higher in care facilities, and during a lockdown, there's a risk for abuse on all sides in that kind of a situation. But whether or not we've seen an increase, I don't know. And I know that concerns would be investigated if a complaint came in, but it is a complaint-based system as far as I know.
Thank you. And Bill, I'm looking at the clock here. I think we may be getting close to the end of our time. Shall we take another question or shall we wrap it up?
I think we should take one more question, but and I also think we have record of all these questions, so we'll do our best to get answers and post them for everyone so that people who have not gotten their answers live today will see them when we repost the recording of this event.
Thank you very much, Bill. And one question from Paul. He asked Dr. Brake, what type of housing do you advocate for rather than the large buildings we have now for long-term care and seniors housing?
I think we should do a total paradigm shift away from the majority of our funds going toward institutional care to a shift towards community-based types of housing. And I think that in turn will reduce the risk of infection, and which is, you know, you can't avoid it when you're in an institutional type of environment. In Canada, we have chosen, we as a society have chosen that large long-term care facilities are the best options for older adults. So to me, let's do a paradigm shift. Let's move towards advocating and lobbying for if we need end-of-life care or long-term care at the end of life, then those spaces should look a lot different than having 460 people, you know, within 2 buildings. And, you know, that's the kind of approach that we've been taking. So that's what I would advocate for. I mean, there are many different ways we can do this, but we need to start talking about that talk. I tell everybody I've got a vested interest in this. And my son and daughter-in-law keep saying, God, Mom, we're going to have you forever. but I really mean it. I mean that this is not, I have no clue why we have chose to deinstitutionalize children. And we talk about the deinstitutionalization of people with mental health and addictions issues, but we got no problem at all to say, oh yes, well, we're going to institutionalize seniors, because we won't even use that word anymore. We won't even say that word. Obviously, this is a bit of a passion of mine. It's it's one of the things I want to talk about and get it out, get it open. People start talking about it. But you need to have the community-based services and the education, knowledge, oversight. You got to have all that in place. So you got to make a paradigm shift towards doing that if we want to start to lessen the numbers of long-term care facilities.
And if I could jump in on that, Suzanne, I wholeheartedly agree that the resources need to shift a little bit, and more attention needs to be paid on what's been called aging in place. And a plug for my mother again. She finished her PhD in the not too distant past, and her PhD research looked at women over 85 who were living independently in rural PEI. And one of the factors that came out, or some of the factors that came out of her study, was the fact that these women were able to live independently with very few extra supports being put into place. As a result of that study, there was a public presentation done by these women on how they were aging successfully in place. And the minister of the day, who was responsible for seniors, attended that session and spoke to all those women, went back to her office and actually created a program that dealt with the fact that a lot of people just need a small thing to help them stay in place. So snow removal, or someone to cut the lawn, or these small pieces that weren't related directly to health, or weren't related directly necessarily to repairing their housing, but were critical for them to age in place. And that program was instituted on PEI for lower income older adults anyway. So that is making a difference in helping people age in place. One of the best features I think that came out of Olive's research was the fact that it was really about nothing about us without us. And that was something that resonated with me, that if you want to help people age in place, then for heaven's sake, talk to them. That you shouldn't be creating programs and policies and the like without actually listening to what the needs might be directly from the people who need it.
Thank you very much, Vicky. Bill, did you want to give a final few words? And maybe I'll just, before you do, I'll add a couple of comments that I've seen coming in. It says, Sharon Cunningham says, thank you for this informative and thought-provoking event. And Bev Gallagher says, thank you for doing this. Please do it again. and I'm sure it will become more popular once the word spreads.
Good. Well, thank you. Thank you to the, at one point, over 200 people who joined us today. Thank you to the panel. Excellent presentations. I'm so pleased that we have recorded this, so we're going to be able to review the suggestions and comments, and we'll also one way or the other get to answer the other questions that couldn't come live today. We urge you to watch the CARP websites, both the provincial where they have them and the national website, and also the CARP Facebook pages. There's one of those in each of the provinces where you'll be able to see the recording of this event today. Share it with your friends, and please don't hesitate to get in contact with any of us. Sharon in Newfoundland, Ron in Nova Scotia, Alphonse in New Brunswick, and Vicky on PEI, or me from any of the provinces as the Vice Chair of CARP responsible for Atlantic Canada. I'm very interested in hearing more from all of you, and I think this is the beginning of moving forward. If you'd like to do another of these events, get in touch with Anthony Quinn and say, Anthony, we need to do another of these again. And so thank you to all of you for taking the time to do it. Really appreciate it. I think this has been a real success and something that we're going to want to do again in the future. Back to you, Anthony.
Thank you very much, Bill. Thank you very much to all our panelists once again, and for all of our members and even those non-members who managed to join us. Please consider joining CARP. If you're not currently a member, we'd love to have you. We've actually created a special offer for anyone who is interested in joining. If you visit carp.ca/Atlantic offer, there's the best price available for you today. So carp.ca/Atlantic offer. And with that, thank you very much to everyone for joining us today. I do hope to see you all again. Thanks and goodbye, and happy Canada Day to everyone tomorrow.
Thank you.
Canada Day.
Thank you.
All right.
Thank you.
Thank you.